Hello, I'm Professor Yang Seung-min. You extract a tooth and place an implant and do careful suturing before finishing the implant surgery. All the steps are very important, especially the suturing is the last step of surgery and it is really important step. Let's look at how to make an incision step by step. Today we are going to look at these requirements for successful long-term stability of implants, principles of flap design, principles of incision, horizontal incision, and vertical incision. Lastly, summary. First, for successful long-term stability of implants, what are the requirements? Just the soft tissue stability or hard tissue stability would not be good enough. Both of them should be stable. For long-term successful stability, soft tissue and hard tissue need to be stabilized. Here, the patient has a periodontal disease and we need to place an implant there. The gingiva, the height of gingiva needs to be stabilized and the hard tissue in it should be stable for successful long-term stability of an implant. For successful soft tissue and hard tissue management, we need to know certain knowledge. So we need some knowledge. Based on the knowledge, we need to identify what I can do versus what I cannot do. We need to have an understanding of these to identify what I can do and what I cannot do. If I just force myself to do what I cannot do, it will eventually create some problems. So identifying these would be very important. First, what do I have to know? What I have to know is preparation for surgery and the principles for soft tissue management. For soft tissue management, we need to have basic anatomical knowledge in order to derive the outcome that we want. So we need to know the blood supply direction and the tension of flap or the tension of surrounding tissues in order to know what we can do based on the knowledge. So we have to identify what I can do and what I cannot do. Before making an incision, we need to design a flap, the principles of flap design. Flap design, how to compose a flap. We need to consider anatomical structures. That's very important. If the area has a mental foramen, how do we need to make an incision? We need to avoid the area where a nerve exists. So the location of incision should be understood by considering anatomical structures. That's the first thing. Secondly, sufficient visibility is important. So the design should be made so that we can fully view the site. Wide flap design is good. If the flap is narrow, it can be helpful. However, if it interferes with the visibility, it may not be very good. So you need to secure the visibility of the surgical site To help healing of the site, blood supply should be made. So you need to consider blood supply in designing a flap. Preservation of keratinized gingiva is important, but in some areas there is no keratinized tissue, then we can do some additional surgery to preserve the keratinized tissue, and that will be discussed in a later opportunity. When you design an incision, you have to include the periosteum. There are procedures that exclude the incision of a periosteum, but other than that, you need to include the periosteum, the reflection of the periosteum from the bone when you design a flap. And many people overlook this. You need to pay attention to minimal trauma on the tissues. So the design should be made that way. If you look at here, this is like a trinity: incision, flap management, and sutures. Those three need to be combined for successful tissue management. None of them should be handled carelessly. So we will look at all those three today. Once again, these three: incision, flap management, and suture. As I said before, the first purpose of making an incision is that it should be atraumatic. Flap management, as I said before, we need to get visibility of the surgical site. Depending on that, the surgery can go easily or with difficulties. The suture should be made tension-free. If you adhere to these three principles, the soft tissue management can be done easily. Preparation for implant surgery is important, as I said before. In the sequence of surgical steps, you need to order the instruments: diagnostic tools, incision instruments, flap elevation tools, and suturing instruments. They are lined up in the sequence of the steps of surgery, and you will have less difficulties if those are aligned like that. Let's look at incision instruments. The blades most commonly used are number 12, 15, and 15C. Many doctors already know this. There is a working end when it comes to a blade, and that's something important that you need to use it. So as you can see here, you have to rest your fingers, and the working end should be pulled toward you to make an incision. So there is an edentulous area. The incision is made like that, and the blade should be pulled toward you. If I'm at the mesial side, the blade should move mesially. This picture is very important. Number 15 blade that is commonly used. The blade has a curvature. Even though the incision that we want is made, the deep part of the tissue may not be cut completely often. So you need to make an additional incision so tissue is completely detached from the periosteum to reflect the flap properly. The same goes for number 12. Inside the working end, the blade exists inside, so you need to pull it toward you. As I said before, when you use number 15, the incision cannot be completed, so number 12 is used to finish, to wrap up the incision, and then complete incision can be achieved. So if you apply it clinically, first number 15 is used to make the incision, and number 12 is used to complete the incision if number 15 could not cut all the way. Then you can simply reflect the flap. When we do a surgery, we often make mistakes. We use repeatedly the same blade. When a blade touches periosteum, the working side gets dulled. So if you use it repeatedly, you can damage tissues. Therefore, when a blade touches periosteum and if you need to do incision again, you need to change the blades to lessen the damage to tissues. When we make an incision, there are principles to adhere to avoid damaging tissues. The first principle is you need to have stable finger support in order to reduce the risk of making a mistake during incision. So you need to have very stable support for your fingers. As I said before, number 12 and number 15 have working end. So it is not the point of blade, but you need to use the curved part. And you need to make sure the blade is facing the direction of incision. For example, if I use number 15, the working end, the curved part, not the point of blade, should be pulled toward me. Next, you can use pull motion or push motion. If you push, if you look at the blade direction, it's the opposite from what I said before. As long as the working end is used, you can pull or push. But usually, considering finger support or finger rest, pull action is a little bit favorable. So many clinicians use the pull motion, but you can change the blade direction to the opposite side to use push motion. The incision should not be placed in the bone defect. If the bone defect is not completely healed, the soft tissue is not healed as well. Therefore, tearing can occur to the soft tissue. When a horizontal incision is performed, whether it should be in the keratinized gingiva or not, that makes a difference. So it should be done in the keratinized gingiva. When you make an incision, you need to consider the blood vessels. That helps healing. From the beginning, try to make a deep incision involving periosteum. In a periodontal department, when we do the designing, the purpose of performing a surgery is to eliminate pockets depending on the depth of pockets. The first incision is done not up to periosteum, and when the depth is identified, the second incision involves periosteum. However, for implant surgery, we know the depth of the placement, so we need to do incision up to periosteum. After extraction, the soft tissue is not completely healed. So in this area, if you make an incision here, tearing can occur. So you need to position the incision lingually over the healed area. So after making the incision, the tissues can be protected and we can check inside. When we make an incision, the area where implant is under, if it is in the middle, if you make an incision over it, you will end up lack of keratinized gingiva. So you need to make an incision involving the keratinized tissue. After that, implants can be placed. Of course, intentionally, we can include a lot of keratinized tissue to make an incision to preserve the keratinized tissue, but I will talk about it at a later opportunity. There are many types of incisions. Generally, crystal incision is made over keratinized tissue, or crystal incision away from the keratinized tissue, and a trapdoor type incision, an incision along the surgical site. If you compare them, after implant placement, bone loss differs. So considering that crystal incisions into the keratinized tissue create the most predictable levels of soft tissue healing and has least alveolar bone loss as reported in late 1990s. So incision should be made in the keratinized tissue. If you look at the histologic picture, the alphabet Z indicates the area without blood supply. So that is called linea alba, avascular zone. That is the top of the crest. Clinically, we do not really know the exact position, but based on our experience, that is the top of the crest. And you will know where it is. That is the avascular zone. So you need to make an incision there for better healing. When you place an implant, the incision should be made up to periosteum to avoid the damage to tissues. So the incision is made like that and the flap is lifted. The flap includes periosteum and you can see the bone below. Intentionally, we can use this procedure not to cut the periosteum. The remaining keratinized gingiva is very narrow, so we try to leave the keratinized tissue and move it buccally. So it is not cut clearly, intentionally. So partial flap is made. Apically repositioned flap is used using this kind of incision to preserve keratinized tissue. And when it is healed, the keratinized tissue surround the area. Looking at this, compared to the initial state, you can see more increased keratinized tissue later. For horizontal incision, it should be made in the keratinized gingiva and over the crestal part. And when you make an incision intentionally, depending on the purpose of the intention, you don't have to cut all the way to periosteum. And another incision is the vertical incision. Vertical incision, when you use a vertical incision, you can limit the surgical field. You can make a wide incision, and if you make a narrow incision with a vertical incision, the surgical field can be limited, so you can secure visibility and you can make a small flap design with the vertical incision. When you elevate a flap, this helps. So when you check the surgical field, this can help. But more advanced approach, when you position upward or downward flap position, there are better procedures that can be used, but without that, this vertical incision can help limit the surgical field. So incisions can be made like this. As you can see, interproximal, mid-labial are not allowed. Primarily, it should be made on the line angle. The blade direction should be apical coronal. That's the principle. However, depending on surgeons, apical coronal or coronal apical can be used based on your experience and the design of a flap. Summary: for successful soft tissue management, as I said before, incision, flap management, and suturing need to be combined organically. The first step is incision. The principles of incision would determine the flap management and sutures. Thus, as I said before, if you observe the principles of incision rigorously, sutures and flap management can follow. If you deviate a little bit from the principles of incision, suturing or a flap management can be facilitated, but the first step is the incision, and you need to follow the principles for successful completion of surgery. When you place an implant, you need to use an appropriate blade for the incision, for the minimal incision, to reduce the failure rate. However, when you treat patients, unexpected events can occur. Master course is designed to give you the armamentarium to deal with the unexpected situation. Thank you for your listening. Thank you very much.